everyone, and welcome to the Commonwealth Club. I'm Mark Zitter, chair of the Zedema Project, a member of the club's board of governors, and your host for today. And today, I should mention, is September 18th, 2020, 6 months after Bay Area health officials announced the nation's first shelter-in-place order, and 6 months to the day after I hosted the club's first program on COVID-19. Now, to remind you of what it felt like to all of us back then, here's a clip from my introduction of that program on March 18th, 2020. Take a look. Today is March 18th, 2020. We are living in an historic time. The coronavirus and the disease it causes, COVID-19, are spreading rapidly and have changed life as we know it, and this seems to occur on a daily basis. My wife is a hospital-based physician, and as such, she's usually a day or two ahead of me in thinking about this. And what I've found is each time she suggests something as a restriction, it seems a bit extreme. But by the next day, it seems utterly rational. We also found just on Sunday, the Centers for Disease Control and Prevention recommended that we limit gatherings to only 50 people, no more than 50. But by the very next day, the White House, which has been criticized for not being aggressive enough in its response, lowered that number from 50 to 10. That same day, Monday, California, the Bay Area, issued a sheltering-in-place mandate for everyone except those with essential jobs. And as most of you know, most California public school students, most employees are staying at home. Then yesterday, Governor Gavin Newsom said that we should be prepared for public schools to stay closed for the rest of the academic year. Most colleges have already made that decision with graduations canceled or postponed. On that day, we had 7,500 COVID cases in America and 100 deaths. We now have 6.6 million cases and, of course, about 190,000 deaths. How much this world has changed in 6 months. Now, we're going to be talking about COVID-19, but first I want to tell you that this is, of course, another program in the club's series, virtual series on the coronavirus in association with the Zedema Project. And I want to encourage you to please visit the club's website, commonwealthclub.org, to stay informed on COVID programs and other topics as well. The programs are free. This one is generously supported by the Chan Zuckerberg Initiative and a collaborative of local funders and donors. And I encourage you to join them. You can go to our homepage and make a donation to support both this series and to sign up for our virtual fall gala. These contributions enable us to continue the club's 117 years of outstanding public affairs programming. Okay, back to COVID-19. After 6 months of what seems like all COVID all the time, I bet you think you've learned a lot about the disease and how to prevent it. So today we're going to test that knowledge in a unique interactive program. I will ask you some questions about COVID that really matter in terms of keeping yourself and others protected, and you'll have the opportunity to answer them, whether on your computer or tablet or phone. Then our expert guest will discuss the best answer to each question. And the good news is there's no pressure here. Participation is optional, though it should be fun. And you can't fail. The responses are all anonymous, so only you know if you've gotten an answer right. Okay, we're going to put your instructions up on the screen for a moment. They're also in the YouTube program description, and we're going to put them in the chat from time to time as well. They should be pretty simple. You can use either a browser or a texting program to do it, and start logging on as you see these instructions as I introduce our guest. Brought back by popular demand, Dr. John Swartzberg was on the program that I hosted 6 months ago to the day. If you think you've learned a lot about COVID-19 since then, I bet he's learned even more. Dr. Swartzberg is clinical professor emeritus in the UC Berkeley UCSF's Joint Medical Program's Infectious Diseases and Vaccinology Division. And he's also the chair of the editorial boards for both the UC Berkeley Wellness Letter and the Health After 50 newsletter. Just a couple other comments on today's unique program. First, we wrote the questions really as teaching tools and the answers as well. We're not trying to generate data that we could use for some scientific publication. But I think you'll find them interesting and provocative. And also, we will, of course, invite you to submit questions for Dr. Swartzberg. However, we won't have quite as much time as we usually do because of the many questions that we're asking you. And by the way, for the final question we will ask you today as a poll, we're going to ask you how well you liked this unusual format. So let's jump right in. These questions will all be multiple choice with one exception. That's the very first item. For this one, I'd like you to type in just 1 or 2 words. Write in 1 or 2 words that come to mind when you hear prevent COVID-19. This is basically just a question of, I guess we call it word association. When you think prevent COVID-19, what first comes to mind? And I'll give you just a moment to fill out some of your thoughts. This will create what we call a word cloud. You'll see things popping up, and depending on how many people use any given phrase or word, the word will show up as larger. This will be the only time we'll do this today, but I thought this would be a great way to get us all started. And John, I'm going to be interested in whether you are surprised by any of this. Usually you get things that you expect and a few things you don't as well. But interesting what people think about when they talk about or hear about preventing COVID-19. I know we have a particularly well-educated audience here at the Commonwealth Club. But we're seeing a lot of different things. All right. So what do you think, John? It looks like masks and wearing masks are some of the biggest ones. Of course, and we've got other things like distancing.
Well, I'm impressed. I think that I go along with what everybody else is saying. I would put masks and social distancing right at the top, and that looks like what most people are doing. Everything else that's listed there is also important, but if you had to prioritize them, wearing a mask, social distancing, you're not going to get COVID unless you get exposed to people when you don't have a mask on, usually, or if you're too close to them, usually. So doing those things really does work.
Great. Okay, we're going to make the questions a little harder as we go forward. I'm going to put up the next question next. And that is, and this time it's a multiple choice question where you actually can choose more than one. If you're on your browser, you can just click them as up to 3. And if you're texting, I think I have to do 3 consecutive screens for it. But in any case, here it is. What are the most important things that an individual can do to avoid contracting COVID-19? And you may think it should be something like getting more sleep or eating healthy foods. Vitamin D has been talked about a lot, although we don't have that as one of the items. But also we've talked about social distancing, talked about masks, particularly within 6 feet of others, avoiding large indoor gatherings, quarantining if you're exposed to someone who is diagnosed with COVID-19. I promise that more than one of these is particularly important, but which 3 would you pick overall? John, there's probably others we could have put up here as well. We tried to say the major ones. And obviously, we're talking about things you can do today. We could put up get a vaccine, but you can't do that today, at least not any vaccine that I've heard of. I think maybe some of the people in Russia think otherwise. We've heard that announcement. But clearly, we want to keep ourselves healthy, and then there's specific actions that we can take. So I'll be curious to see what people think are the most important items. And it looks like we've got several winners. Practicing social distancing coming up near the top. Wearing a mask, of course, within 6 feet of others. We've already talked a bit about that. Avoiding the indoor gatherings is very important. Quarantining, interesting. A number of people picked that as well. Quarantining is important. But let me have you comment, John, on these responses. What do you think?
Sure. Well, I go along with the group. Social distancing we talked about, masks we talked about. It's important to emphasize the indoor gatherings. Indoors is much worse than outdoors. And it's purely because outdoors, the virus gets diluted in such an enormous volume of air, as opposed to indoors where the virus doesn't get diluted. And depending upon how much air is circulating indoors, determines how far that virus can go indoors, and perhaps could even go further than 6 feet, depending upon if you have good circulation and poor circulation. So I would put those 3 at the top. Just as another sort of tangential observation, Mark, it's apparent that all our listeners really get it in terms of what's important, how to prevent getting infected. And then you look at places like Lake of the Ozarks on Memorial Day, the gatherings up in Sturgis, South Dakota, and some of these rallies that the president's holding. You think, why are people doing that if everybody really knows? There was a mathematician who published a paper about a month ago that was intriguing. He said that each person on average knows about 600 people in the United States. I don't know if that's true or not, but that was his assumption. Given that, we'd need to have about 500,000 deaths in the United States before, on average, every person would know somebody who died of COVID. And I think right there lies part of the problem, is that for a lot of people, they haven't seen the tragedies that COVID causes, both in terms of serious morbidity and mortality. And especially since a lot of the morbidity and mortality with COVID occurs in marginalized groups in our society. So I think until Americans start to see their friends, the people they know who are dying, even though they intellectually understand, hopefully then they would start to, before that, they would start to respond more appropriately.
Haven't experienced it. Yeah. Now, to be fair, answer F, the quarantining was a little bit of a trick question, right?
It was. It's a great answer. Certainly superb. I was focusing my answers more on the what you could do individually to prevent getting exposed in the first place. But clearly, quarantine, if you're exposed to someone, is the right answer.
Yeah.
Eating healthy foods and getting sufficient sleep, those things are important, of course, for all disease.
Yeah, but they're not going to help you quite as directly as some of these other things.
Right.
Let's go to the next question. It's a simpler one, and that is the primary way that COVID-19 is transmitted between people is by, and if we have to pick one, is it infected surfaces, shaking hands or hugging, breathing infected air indoors, breathing infected air outdoors, something else, or, and you'll see this answer in several of our questions, we don't have sufficient data to know. So let's see what people think about this one. I will say that, John, my understanding is we've got all kinds of scientific models for these things, which keep getting better. However, it seems like much of the best information we have about this, the real evidence, comes from contact tracing. I think is that correct? Where we see what people say when we know they have caught it from somebody else.
Right, the real world.
Yeah, which is the best way, and that's why I think have some good data on some of these and less on others, and sometimes it's just the absence of data that makes us infer certain things. But overall, we're looking at when someone is infected and we contact that person and contact their contacts, and we see who has caught it, and we say, well, how did you interact with that person? Did you touch them or shake hands, or were you? And of course, sometimes they don't even know the other person, but they were in the same area. Sometimes they actually have hugged or kissed or touched or danced with or wrestled with or whatever it might be. So we'll see how people vote on this one and what we see. What do we have here? Okay. Breathing infected air indoors, by far the one most commonly selected. What do you think about that answer, John?
I think it's what I would have selected too. I know it's what I would have selected too. You know, it's not that infected surfaces or shaking hands aren't important. We just don't have as much science to support that in terms of being the most important way of transmission. Nevertheless, it's very difficult to prove a negative. So clearly, I and everybody else in public health and medicine would urge people to keep their hands clean. Try not to touch anything that might be infected. And if you do, soap and water. And if you don't have that, then alcohol, 60% or more on your hands. We talked before about breathing outdoor air. It's a risk, but not nearly the risk of indoors, which almost everybody put. The fact is that number F is a perfectly reasonable answer in many respects. Because as you were saying earlier, Mark, you know, we don't have a tremendous amount of science here. We have some, and the contact tracers have been very helpful in telling us that indoor breathing air is the most risky. But there's a lot more to be learned. For example, when we talk or yell or scream, we not only create droplets that go within about 6 feet, but we also create droplets that are lighter than air and can stay in the air for a long time. That's called airborne spread. And there have been documented cases of people getting it through airborne spread considerable distances away. It just is not nearly as common as closer in. So yes, I would have picked number C.
Okay, good. And the good news is, even though, again, like you say, it's hard to prove a negative, my understanding is we don't have evidence of many people catching COVID from mail or packages, from food being delivered or groceries being delivered. That might happen, but we don't really see that in the data. So we're optimistic that that's not a big problem. Is that correct?
I think that's correct, but I'm certainly not anywhere near the point of saying that hand washing or alcohol in your hands isn't important.
Right. Very good. Okay, let's go to the next question. Which of these factors does not usually have much impact on whether COVID-19 spreads? By implication, all of these except one does cause COVID-19 to spread, or is a factor, I should say. The length of exposure to an infected person, how close you are, the physical proximity, whether you've been exposed to somebody indoors, the body temperature of the infected person, and what they call forced expiration, meaning singing, shouting, yelling by the infected person. 4 of these actually are important, and one of these is not. So pick the one that you think is not important. There may be many others as well, but the 4 of these have kind of been fingered and determined to be the things that most often have the biggest impact. And this is important because, of course, if we're trying to avoid certain things, we want to use this as a template for it overall. So let's see what our group thinks about what's most important. I know I've read a lot about many of these different things and seen examples of them, and it looks like we've got 2 things that people think are most important. John, which do you think is the one that is least likely to have an impact on whether COVID-19 spreads?
Well, Mark, I think you put in there sort of a tricky question there, but I would definitely pick number D. The reason why I thought it was a little tricky is because I think what you're getting at there is that asymptomatic spread of this virus is terribly important in terms of infecting a lot of people. What I mean by that is that at least 50% of the people who catch COVID from somebody else, catch SARS-CoV-2, the virus, catch it from somebody who's asymptomatic, or what we call pre-symptomatic. That is, they don't have symptoms but ultimately will get sick. So looking for body temperature would only capture those people who are symptomatic. And we don't want to emphasize that because that's at least only half of the population. So, and furthermore, of course, there are lots of reasons why people would have an elevated body temperature besides COVID. So yes, I wouldn't want to be around somebody with an elevated body temperature, but I really don't want to be around anybody because I can't tell if they're infected or not.
Right.
That's the key point there. The forced expiration is really worth dilating on just for a moment. There have been some very important outbreaks associated with people singing, playing musical instruments, where are shouting or screaming that have clearly spread this virus. So just my talking right now is expelling, if I was infected, would be expelling virus. But if I was yelling at you or screaming at you or singing next to you, that would be expelling a lot more viral particles.
Matters a lot, yes. And I know with the Jewish holiday of Rosh Hashanah starting tonight, there's some concerns about people blowing the shofar, the ram's horn, very important part of the ceremony, that can expel the virus as well. So there's been some plans made for that. Okay, the questions are going to start getting harder. I just want to warn you. The next one is, which of these is not a common symptom of COVID-19? There are many symptoms of COVID-19. We've picked 6, and then we've got a decoy in here, one that's not a common symptom. So do you think the one that's not common for COVID-19 is fever or chills, cough, sneezing, breathing difficulties, whether shortness of breath or something else, a loss of taste or smell that you haven't had before, headache, or diarrhea? Lots of different symptoms. In fact, one of the problems with COVID-19 is that it has so many different symptoms that people present with, and not all of them usually, it's just some of them. And it's taken us a while to figure out whether something truly is a symptom of COVID-19. And of course, some of these symptoms obviously are similar to other health problems that are not COVID-19, in particular the flu. We're going to talk about the flu a little later. But one of the challenges is, how do you recognize if you or someone else might have COVID-19, remembering also that, as you pointed out, so many people are not symptomatic at all. So the top vote getters here, John, for the one that's not a symptom are sneezing, followed by diarrhea, headache, or the loss of taste or smell. Which is the correct answer here?
I would have put number C first, clearly. And it's not that people with COVID won't be sneezing. They can be. But it turns out when you look at large case studies of people who developed symptomatic infection, sneezing is not a particularly common symptom that they have. And it's a very common symptom, for example, of allergies or the common cold. So of all of those listed there, I agree that C would be the most likely. It's interesting to look at a few of these others, though. You know, when this virus started, we thought it was going to be just like influenza. Coronaviruses are just a respiratory virus. They would cause a picture very similar to influenza. And then by about late February, we started to see these reports of people who lost their smell, the ability to smell, and sometimes the ability to taste as well. And that has turned out to be one of the most common presenting symptoms of people who have symptomatic infection with SARS-CoV-2. And that's been something we don't typically see with other respiratory viruses like influenza. Headache is certainly seen with patients with COVID. And that's same thing associated with fever and chills. When you have fever and chills, usually you have headaches because of a lot of these chemicals floating around in your body. And the last thing I want to comment on here is the diarrhea. The virus gets into our cells by these receptors on our cells called ACE2 receptors. I won't get into the weeds here too much, but we thought those ACE2 receptors were just located in the nose, the back of the throat, down the airways into the lungs. But now we know that those ACE2 receptors are found in the heart, the gastrointestinal tract, the kidneys, and many other places. And that means that COVID can present with gastrointestinal symptoms, particularly in children, where diarrhea is not an uncommon presenting symptom. So I agree with our audience. Sneezing, diarrhea, sneezing would be clearly number one.
Yeah. Well, my takeaway from this is that since we usually just assume that if someone's got a virus, a respiratory virus, they're going to sneeze, that's been a real scare around here. But the fact is, if you see somebody sneezing and you think COVID-19, that's less likely that's the case. On the other hand, there's very few diseases that cause to lose taste or smell. So I think they're finding that to be fairly specific for COVID-19.
Yeah, but again, somebody sneezing, I wouldn't want to be around them anyway.
Yeah, anyway, right. That's true. Okay. You know, we were worried about the death rate from COVID-19 and what that was going to turn out to be. So what has it turned out to be? On average, if someone contracts COVID-19, how likely are they to die? What percentage of those die? Is it 0 to 0.5%, 0.5 to 1%, 1 to 2%, 2 to 4%, 4 to 6%, 6 to 10%, or more than 10%? And of course, here we're just talking about the average. We're talking about you take all those COVID cases we've had that have resolved in one way or another. How many of those people have died? A very important rate, obviously, since death is about the worst thing that can happen from COVID-19. You know, as we started out, we weren't sure if the death rates we saw in China initially or elsewhere were going to be similar to the ones we saw here. We weren't sure if they were going to be similar to other SARS, sort of same family of diseases, some of which have been, and some other major pandemics have had much higher infection rates, you know, in the double digits, to double digits. So this is something that the epidemiologists and public health people have been watching very closely to figure out what we can learn about likelihood of dying. And I know that we've also had some changes in the death rates as time goes on. We'll talk about what some of those will be too. So curious to see if people have a sense of how likely are people to die on average. Okay, so we're getting 1 to 2% as the most common response, with 4 to 6% second and 2 to 4% after that. John, how bad is it? How likely are we to die if we contract COVID?
Well, this is the first time that I don't agree with the audience. I would put B. The number that the CDC quotes, this is for all, as you said, Mark, all ages, all different kinds of underlying health problems. The number is 0.67% here in the United States. But as you also said, it's a moving target. Earlier on, we were seeing numbers of 2 to 4%. But most recently, actually in the last few months, the numbers have significantly dropped. A couple things to comment about this. First of all, when you were talking earlier that we're approaching 200,000 deaths in the United States, which is just a tragedy, and a lot of this was unavoidable. But those deaths are underestimating the actual number of people who've died either directly or indirectly from COVID. Repeated studies have shown that they probably underestimate by at least 10%. So we've had more than 200,000 people already die of this disease here just in the United States. The other thing to point out is that to emphasize what you had said, Mark, about on average, because if we were saying on average, if you were 75 or older, the answer would be G. The numbers are much higher. And if you're 85 or older, the numbers are probably close to 25 to 30%. So a lot of it varies tremendously upon how old you are and also how healthy you are. And again, I wouldn't say that just because you're older, you're going to be in those statistics. If you're older and very healthy, you're probably not. But overall, so about 0.67%. And you can contrast that with influenza, that overall the number's about 0.1%. So we're roughly about 6 to 7 times more likely to die from COVID than influenza.
Yeah, and 0.67% times a large population like ours, if many people do catch the disease, turn into a lot of deaths. Now, of course, although, as I said, death is the worst thing that could happen with COVID, arguably, it's not the only thing that can happen. So someone in the audience conveniently just asked a question that anticipates the one that we had pulled up anyway. And that is for those who have had COVID symptoms and then recover, the likelihood that they will have lingering health effects is, and here we are with one of those questions. You don't have to quantify this, but do you think it's very low, extremely low, moderate, high, very high? Do you think the main issue, we just heard that death is dependent a lot on age in terms of probability, but what about lingering symptoms? Is that depending on age or underlying health status, or do we just not have the data to know yet? This is important because, of course, fortunately, as we've seen, almost everybody who gets COVID doesn't die from it, right? More than 99% survive it. However, that doesn't mean that they are unaffected, not only during the time they have the disease, because many of them go into the hospital, but even afterwards. What about people who've had bad symptoms? And of course, we know many people who get COVID don't even have symptoms. And we're curious as to whether any of them have lingering health effects. Now, of course, we can't really tell long-term because COVID hasn't been around long enough to know if any lingering health effects last more than, 6 or 7 months. But still, since most people recover within weeks, we do have some evidence, something we know about whether things last longer than that. So let's see what you think. Do you think it's high, medium, low, or depend on health status, or that we just don't have the data? John, the biggest vote is we don't have the data. And the second vote is moderate. What are your thoughts about this?
Yeah, I think clearly we don't have the data to really have our feet planted in cement on this issue. But we do have some data. And it's been very disturbing what we've seen. It's preliminary, though. And therefore, I think that C would be a very reasonable answer. But it's at least the preliminary data would suggest F is not a very reasonable answer. And let me explain what I'm getting at here. First of all, what we're seeing, there have been a couple of studies now that have looked at people 60 and 90 days out from their COVID infection. And one of the studies showed that 60% of the people at 60 days out were complaining of persistent fatigue. And close to 45% were complaining of brain fog, or just that their brains weren't as sharp, or they didn't feel they were as sharp. Then the list continues to go down. There are some people who continue to complain up to 90 days later, and we don't know much more than that because, as you said, the virus hasn't been around that long. But up to 90 days later, they still can't smell well. They can't. Their noses don't work as well for smelling, and taste it can still be a problem. Now, that a lot of people do get well from that, but that seems to be a persistent symptom. And then I wanted to point out that a lot of these people who have persistent symptoms didn't have serious illness. They got sick and they weren't well, but they weren't in the hospital necessarily. Some of them were. They weren't in the ICU necessarily, although some of them were. But a lot of these people didn't even need to go in the hospital, and yet their symptoms are persistent. So I think G is the correct answer. We just don't have enough data yet. But there's been some red flags now that are very disconcerting, that this is not like influenza that you may feel punk for 6 or 8 weeks after the acute illness, then you're fine. This could be leading us to a population that has chronic problems. One last thing to say. We know that people can have strokes or blood clots to their lungs. They can get scarring in their lungs. These are going to cause often permanent problems. So there are lots of things that we don't know about COVID, and there's lots of things we worry about in terms of persistent problems for our population.
I think the main takeaway for me is that although we might assume, gee, I've got a 99% of not dying if I get COVID, and in fact, it's probably even better if I'm younger, that shouldn't be the only thing we think about. There's some possible, really problematic long-term results and implications for getting COVID, even if I don't feel very sick at the time. So,
yeah,
yet another reason not to want to get it, right?
Yeah, I probably should add just one last thing, if I could. There have been some disturbing reports about COVID causing damage to the heart, maybe up to even a couple months after the acute infection. Very preliminary data, but there are a couple of studies now that have been published that show that this can happen, and we don't know what the long-term consequences of that are.
Yeah. So when people say, younger people say, well, I just hope I get it quickly and get it over with, that may be not something you want to wish for.
Right. I prefer them not to get it.
Yeah, it's probably best. Okay. Well, speaking of young people, how about the youngest? Children under 10. I want to see, do children under 10 actually spread this disease to adults? And this has been a big issue increasingly as we reopen schools in some places. I believe New York City recently was reopening its schools, delayed it again. Obviously, a lot of issues, not only for the children, but for the teachers. We're going to put this poll up here. Do children under 10 spread this? And of course, the challenge is that here in America, children don't live by themselves. So even if they don't get sick from the disease, and we know they don't die from the disease very often at all, the question is, do they become ill at all? Or if not, do they spread the disease to adults? I think you've heard and you've seen a number of different issues in some of the school systems where teachers are either striking or refusing to come in. There's governmental orders about this, so forth. So we're taking a look at what you think about whether children spread disease to adults. And the answer we have here from the audience is most likely sometimes. What do you think, John? What do we know about this?
I think sometimes is a really good answer. But also, E is important to note that we don't have a lot of data about this, but we're accumulating more and more. Just in the last month, we've learned a lot. So I agree with sometimes is probably the best answer here. It's a little tricky, your question though, Mark, because it's clear that particularly children under 5, it's very unusual for them to get very sick. It's typical for them not to get sick at all. And we found that children under 5 it appears that they don't have as many of these ACE2 receptors for the virus to get inside of our cells, and that may be the explanation for that. Another thing we've learned is that children under the age of 5 are less likely than older children, teenagers, and adults to spread the virus. Interestingly, in the most recent study I've seen, that children over 10, or even over about 8 or 9, seem to have as much virus that are infected, seem to have as much virus in their secretions as teenagers and adults. And teenagers and adults have just pretty comparable amounts. So I think what all this tells us is that children can be a reservoir for this disease. They can bring it home to their parents. It's probably less likely that that's going to happen with children under 5, but just in the last 2 weeks, we've seen reports of children in daycare bringing it home to parents, and one parent had to be hospitalized. And one of those reports was in Marin County. I believe it was Marin County or in the peninsula. So we have to recognize that while children don't get sick as much as adults, they can. And even if they're not sick, they can spread it to adults who can get much sicker.
Okay. And what about the age range a bit above that? The next question we have for polling is adults aged 18 to 34 are unlikely to become seriously ill if they are infected. We already talked about they can have some sequelae, but what about the actual likelihood? We know so many people are asymptomatic. To what degree are adults, young adults, likely to be or unlikely to be seriously ill if they're infected? So here we made this an easy question for you to answer, at least in terms of the structure of it. Strongly disagree, to strongly agree, or something in between. And if you think there's not enough data to really know, you can pick letter C. I think this is important because, of course, these are people who are at college. They're going to work for the most part. These are the people most likely to be out and about, if you will, rather than, I mean, certainly some can be working from home. But also we know we are social creatures. People 18 to 34 are most likely to be single social creatures who are running around and want to interact with other people. Many people, when they get to older ages, are already living in households. They can have their pods and still have some kind of social interaction. So a lot of concern and interest in this age group in particular. And I believe that in the increases in COVID in the last number of months, we've particularly seen this age group being held responsible, thought of as being particularly responsible. So we've got general agreement, 50% saying that adults aged 18 to 34 are unlikely to become seriously ill if they're infected, but certainly some disagreement and a lot of neutrals too. What do you think, John?
Yeah, I'm somewhere between B and D, like everybody else. I think it depends upon how you interpret likely or unlikely. It's clear, as we've been discussing, that this age group is much less likely to become seriously ill than the age group above that, particularly the much older age group. So there's no question about that. But I think one of the misconceptions that the population has is that people in that age group, 18 to 34, don't become or really have a get out of jail free card. That is, they're not going to become seriously ill, so they don't have to worry about it. And just ask these two patients in the last 3 months who have had to have double lung transplants. Both in their, I believe both were in their 20s. One might have been in their early 30s. So it can happen. People in that age group die. People in that age group can get very sick. It's just much less likely.
Okay. Here's a very different question, but one I think that's got a lot of practical implications for everyone. Should I have a flu vaccine to help combat the COVID-19 pandemic? And we got different answers for you, both yes and no, but the yeses are qualified. Should you get it right away? Should you wait till early October, a few weeks from now? Should you wait till later in the fall? Should you not worry about the timing, but get it definitely if you're in a high-risk group? Should you not get it because it's not going to help against COVID-19 anyway? Or do you have another thought about all this? I know that we were always encouraged to get the flu vaccine. The question is, does it have any relevance at all to the pandemic? A very different issue, although they're both obviously respiratory infections. The question is, how much does that interact? Even whether the flu vaccine might be protective or in some other way helpful. So let's see what the audience says about this one. I know I keep getting notifications from my health plan to get my flu vaccine to it. So here's what we say. Yes, as soon as possible. Early October is the second most common one. And some people think also about the high-risk group in particular too. John, what do you think about this one? You had some insights when we talked about this earlier.
Right. This one I feel really strongly about. The most important thing is please get a flu shot. It's so important. I would have picked B, although A is absolutely fine. Let me give you a little background here. Why is it so important? Really, it's important every year to get the flu shot, but why is it so important this year to get it? Well, first of all, we talked about earlier that influenza and COVID, when they present, that is when they cause symptoms, I as a clinician could not distinguish between the two. So we'd have to do a diagnostic test to differentiate between the two. And we have medications to treat influenza. So I'd really want to know if my patient had influenza so I could get them on therapy. The most important reason to get the flu shot this year is from a public health standpoint. That is, you have to be altruistic. We saw what happened in New York City during the height of the pandemic. We saw pictures of people on ventilators in the ER in the hallways. The mortality rate during the peak of the pandemic in New York City was much higher than what the mortality rates here in San Francisco, not because the doctors were better in San Francisco than New York, but because New York was stretched to its limits in terms of its ability to care for really sick patients. And San Francisco was not. The reason why I'm giving you that background is every year influenza kills around 35,000 Americans, every year. That's just about the same number as Americans that are killed in car crashes. Every year, several 100,000 Americans are hospitalized with influenza. So think about that. Here we are entering influenza season later in the fall and certainly in the winter. At the same time, COVID's going to be circulating. These two together could exhaust our hospital capacity to care for people. And we could be in the situation that New York City was in during the height of the surge, or we could be even worse, like Northern Italy was in during its catastrophic month or so. Influenza vaccine will help prevent that. It's not anywhere near a perfect vaccine. It's going to, on average, prevent about 50% of cases of influenza, which means that it's going to prevent an enormous number of deaths, an enormous number of hospitalizations, which means that those hospitals will now have the bed capacity to care for patients with COVID if it behaves as we expect it will be behaving. So it's a critical issue from a public health standpoint. One last thing, from an individual standpoint, there have been occasional cases reported during the late spring of a co-infection between influenza and COVID. And we believe that that would make the outcome for both of those diseases much worse. So get the vaccine to protect yourself from the flu, get your vaccine to prevent yourself from getting a co-infection, and get the vaccine to make sure there are beds available if you or a loved one or anybody in our society gets very sick and needs a hospital bed and needs an ICU.
Great, thank you.
But I forgot to answer the question.
Oh, yes.
When? I got carried away, sorry. If I had to pick the optimal time, I would pick B, early October. Here's why. And this is a really fine point. Any time is fine. The vaccine, on average, tends to last about 6 months. We know that we start to see influenza cases late October, picking up in November, really picking up in December, peaking in January and February, significant still in early March, and then starting to drift off. So if you get it in October, you're going to be covered for the bulk of actually almost all of the influenza season. If you got it in August, you might have some waning immunity by February or March. And so the optimal time, and this is more of a personal opinion than a scientific opinion, the optimal time would be probably in a couple weeks. But don't despair if you got it in September or even in late August, you're still going to get excellent protection. And certainly if it's in November or December and you haven't gotten it yet, it's still worthwhile getting. So be sure to get it. It takes about 2 weeks after you get the vaccine to be protected.
So get it one way or another is the main thing.
Yeah.
All right. Let's talk about treatments, because we have several different treatments that are being used. And one of the ones that's been most in the news is hydroxychloroquine, which was initially authorized under emergency authorization through the FDA, later withdrawn. President Trump has been much a proponent of this. There's some critics as well, but obviously the FDA did endorse this to a degree for a while as well. So is COVID-19, is hydroxychloroquine an effective treatment against COVID-19? What do we think right now? Are we giving you the opportunities to agree, disagree strongly? Maybe we don't have enough data. Certainly there's been some controversy around it overall. And of course, this is just one treatment. We've got things like dexamethasone and remdesivir and some other ones, which tend to be more employed towards the most seriously ill patients. I think hydroxychloroquine was more thought of as something that might be preventive or might be useful in people who aren't quite as sick initially as well. So let's see what people think about the state of the knowledge for that. There's a lot of strong disagreement and also a number of people who think we don't really have quite enough data at this point. John, what do you think the data say?
Yeah, I would go with A. You can never have enough data, so C is perfectly fine. That said, the data that we have is very strongly shows that there's no clinical efficacy to taking hydroxychloroquine. There are people who passionately claim that it works, but that's based on passion. And for those who looked at the literature, I would say a misinterpretation of the literature. It's also a good example of why politics should not insinuate itself into medical decisions. The fact that the President of the United States was a strong supporter of this, based upon absolutely no scientific knowledge or understanding, it created a great deal of confusion. The fact that the FDA buckled to his pleadings to give it an EUA said a lot about the politicization of our important agencies. There's no good reason to use hydroxychloroquine. There is toxicity to this drug. It's not common, but it can cause a variety of things, the most serious of which are serious heart rhythm disturbances. Mm-hmm. So, no, I strongly disagree.
More downside than upside. Okay. Let's move on to a few lifestyle things. I have been a very frequent flyer in my life, but not lately. And how warranted is that? What's the risk of catching COVID-19 through air travel? And again, we're giving you choices here that are not quantitative, but is it very, very low, or is it pretty low, moderate, high, very high, or do we think we just don't have the data to tell us overall? I know that for many of my friends who travel incessantly, some of them have said I've never been grounded for more than a couple of weeks or a month at a time, and now they've not even come near an airport since March. Which is the case for me as well. So I'm curious as to what the data show, and I'm curious to what people think we know about the risk of catching COVID-19 through air travel. We know the airlines have been seriously hurt by this pandemic, with air travel way down, some substantial layoffs and so forth, and not being clear when that will come back and to what degree it will come back. So let's see what people think about the risk here. And we've got a lot of different opinions here, but moderate is the most common guess or response overall. And some people think we don't have the data. John, what data do we have on this?
Well, we don't have enough data. And I have a little trouble in, I think, interpreting what low means to me. And I'm sure everybody struggles with low, moderate, or high in terms of relative risk. Each of us define our own relative risk for things. Some have more risk tolerance than others. It's low. The risk is low from the perspective that you're far less likely to get COVID flying than you are likely to get it from that perspective. So you have to ask the question, how critical is the air travel? If it's for fun, for enjoyment, would you want to do something that puts you at risk for COVID, for something that is more indulgent in that sense? On the other hand, if you've got a loved one who you may be sick or may need your help, or a situation like that, that would change how you would do the calculus. And a lot of people would certainly want to take a relatively low risk. A lot of it comes down to luck. By that I mean, if you have somebody in the row in front of you or behind you, or the side of you, who has COVID, you're at much greater risk. So that's what it comes down to. If you have somebody in the back of the plane and you're in the front of the plane, there's one outbreak I know of that did occur many seats away or many rows away, but that would be much less usual. So the risk is not like, oh my God, I'm going to get it if I fly. You're unlikely to, but you're playing Russian roulette to an extent. One other thing that I'd emphasize is that when we talk about air travel, and I like the way you worded that, it's not just the airplane. It's how are you going to get to the airport? How are you going to navigate the airport for safety? What are you going to do on the plane to assure the greatest degree of safety? Then when you get off the plane, you're in the airport again. And then when you get to the airport, when you're going to get to your destination. So there are lots of places in between your home and the place you're going that put you at risk.
Yeah, just by thinking about it, my biggest concern might be the jetway. If you have to stand and wait on the jetway, which is not particularly well ventilated and is kind of crowded.
Right. And one other thing you should do is pick a flight where you won't be sitting on the tarmac a long time.
Yes.
Yeah, I wish we could do that. But the amount of air circulating in the airplane once it's in flight is really very good. The circulation is excellent. It's not perfect, but it's excellent. But when the plane's on the tarmac, the amount of air circulating is far less.
Well, if I can't fly, at least I'd like to go out to dinner. So let's have the next question about that. Which of these does not make it safer to dine indoors? Good ventilation, reduced seating density, having all staff wear masks, ceiling fans to circulate the air, or dining only with your pod, meaning the people that you live with, that you're regularly in contact with. We have seen various states, regions, cities make dining accessible, make it only outdoors, allow indoor dining, but with restrictions, reverse some of those when cases in their region started to increase. So we have a lot of different back and forths about whether you're allowed to, and if you're allowed to, what can make it safer. And I know that there's a lot of restaurants I've seen that are trying to be very responsible and implement everything they can to make it safe for their diners to dine with them. Not just obviously delivering or allowing curbside pickup, but actually dining indoors or outdoors. And of course, as the weather changes, as we go into the fall, the outdoor dining will be less of an option in many parts of the country. So curious as about which of these doesn't make it safer. Several of these do. And the top vote here is ceiling fans, and the second one is dining only with your pod so far. John, what do you think about that?
Yeah, I would go with D, and I can certainly understand E. But I've got to tell you that, and I hate to say this, I wouldn't go into a dining to a restaurant indoors. I just think you're not tremendous, but you're putting yourself at risk. Let me explain that. When you're dining, you obviously can't have a mask on. I mean, you're supposed to take the mask off when you eat or when you drink, and then put it back on, but nobody does that. You're in an enclosed area with people you don't know for a prolonged period of time. And if you're drinking alcohol while you're having dinner, which a lot of people do, your inhibitions and your judgment decline, and you're less likely to be careful. All of those things are a recipe for disaster. So I really hate to say this, and I know how hard restaurants are trying and how difficult this is for the people who work in the restaurants and the people who own them. But I think I would not go into I would not do indoor dining. If you are going to do indoor dining, D is, I think, the best answer here. Because ceiling fans are just going to move the air around. And we saw in a large outbreak in China early on in the pandemic, the way the air conditioner was blowing in the room blew the air from somebody who turned out to be infected over to a group of people quite a distance away. And those people got infected. So ceiling fans aren't likely to help. Dining with your own pod would be great if your own pod are the only people in the restaurant and your own pod is serving you and cooking for you and delivering food to you.
That sounds like home, though.
Right. So that D is, I think, the best answer there. But I don't think you should be dining indoors.
Yeah. Okay. And we'll distinguish between fans that just move air versus air filters, some of which might actually be helpful, but those are different things entirely. All right. How about groceries? We talked a little bit about this on Contact. I should be concerned about catching COVID from groceries delivered to my house. To what degree do people agree with this? And this probably is similar to, not identical to, but similar to packages from UPS or FedEx or the post office or even mail. What's the likelihood of having somebody with COVID, not breathe at you or on you, but actually touch a surface when it's a delivery sort of a situation where you could actually then touch that same surface, presumably touch your mouth, your nose, your eyes, or something like that, and pick up COVID that way. I know this has been a concern, although I've seen the level of concern change as the pandemic has gone on. And I'm not sure if that's scientifically based or just because people getting fatigued. But curious about what you think about this, John, and let's see what the audience has said about this point. At this point, we're looking at more disagreement, mostly disagreement about that. So people think that you should be concerned about catching COVID from grocery deliveries. What do you think?
Well, let me just tell you that one of my colleagues at UC Berkeley, who I've taught with for over 20 years, he thinks it's perfectly fine to not worry about it. And so he doesn't do anything. I am a little bit concerned. I think the risk is quite low, but I am a little bit concerned, and I think it's reasonable to wipe things off. I've got to tell you, my wife feels very differently. She's very concerned about it and is meticulous about wiping everything off, particularly before she puts things in the cabinet and in the refrigerator. And I certainly, I always follow what she says. So I think that her argument, which I think really is a good argument, is that you don't know how many people have handled it. And then you may very well have the virus on the product. It's so easy to wipe things off. Why not do that? I can't disagree with that. On the other hand, as we were talking about earlier, we don't know how important it is if you touch something that has the virus on it, you now have it on your hands, and you bring it to your mouth, nose, or eye. How likely is that going to spread it? It's probably very unlikely, but we don't know with certainty. And it's so easy to wash your hands. It's so easy to wipe things off. Why not do it?
Yeah.
That's more of a personal opinion than I can tell you about the strong science.
Yeah. Well, in my experience, this is one where the experts aren't of one mind. Let's ask one more in this vein. What proportion of people who contract COVID get infected from someone who has no symptoms? And this is partly a test to see if you were listening, because actually Dr. Schwartzberg did mention this number early in this program. So whether you knew it before or listening, what percentage is it? 0 to 10%, 10 to 20%, 20 to 40%, 40 to 60%, 60 to 80%, 80 to 100%, or maybe we don't have the data on this one either, although I gave you a hint that we do have some data on that. It's obviously extremely important since the other diseases I mentioned, some of the other SARS family diseases have much higher death rates, but they are more typical in their presentation, meaning people are not infectious until they have symptoms, so that everybody knows, they know and others know that they're dangerous and should stay away from them. This is the opposite. Not as many people die on a percentage basis, but of course we don't know if people are sick very often. So the number one answer here is 40 to 60%. John, is that correct?
That's what the data shows.
Great. They were listening.
Yeah, sure. Well, or they were well informed before.
True.
Absolutely. Yeah, it's this is one of the more insidious things about this virus, and it has really given it an advantage to be able to spread in the human population. Unlike SARS-CoV-1, the one that caused the SARS outbreak in 2002, 2003, people were only asymptomatic for about a day. Here you're asymptomatic for at least 2 days before you become sick, and a lot of people, maybe 50%, may be asymptomatic the entire course of their infection. That is, they never get symptoms, but you can spread it. So when you see people walking around without a mask on, they feel fine and they think, well, I can't spread it. That's why this virus is spreading so easily.
Yeah, it's insidious. Okay. I think we got time for one more question like this and a quick answer from you. And this is one that I think I brought up to you because I didn't know the answer. Will a COVID test detect the disease in the first 3 days after a person is infected? I know we don't have symptoms in the first couple of days, but what if you get the test? Will it show if I have it or not? And we've got a range of answers from no to yes, with probably, sometimes, usually. And also, maybe it depends on the type of test. We're having more and more diagnostic tests out there, and some of them are saliva-based versus nasal swabs, and some of them are rapid and some are not, so forth. So we're having more options and more supply, fortunately. But in any case, are we able to know if we have COVID in the first couple of days after we've been infected? Be great if we did. So I'm curious to see your answer to this one, John, and everybody else's answer. And the number one answer, a lot of people think it's depending on the type of test, and most others think it's probably not. What do you think?
B.
Lee?
The most common test done is to detect RNA, and the chances of finding it in the first day are really low. The second day, low. The third day, moderately low. When you get up to the sixth day, even the fifth day, even sometimes the fourth day, the numbers start to get much better. So early on, we don't find the virus very well. After you're in several days into being infected, even without symptoms, we start to find it. The peak time to find it is about day 6 or 7 or 8.
Great. Well, it's too bad we can't know for sure earlier on, but those are the facts right now. I appreciate that. We have just time really for one last question, and I already told you what it's going to be. The good news is this is a very smart group, and if we had prizes, a lot of people would have run prizes for a lot of accurate answers. This one you can't get wrong because it's just your opinion. And if we could have our tech people skip to the last question on the list. This is really just a question about, for this type of a session where we're focusing on information about an issue, do you like this kind of format, a quiz-based format? The initial format I had 6 months ago with Dr. Schwartzberg was just where I interviewed him about this. So, well, go one back, and it's this one. For this type of information-oriented session, I prefer this format, a poll-based format, to a more typical presentation or interview. No right answer here, it's just what you prefer. So we're curious about whether you would like the club to do more of this kind of program when we're dealing with issues of knowledge and information about a particular issue. It doesn't have to be health related, but in this era of all virtual programming for the club, we're trying to figure out what the audience is going to enjoy the most. So very much appreciate you giving us your input on all of that. And we'll see what people say as we tally the votes. And while you're doing that, I want to remind you to regularly visit the Commonwealth Club at commonwealthclub.org. We have done I want to commend the club for doing an excellent job in continuing to provide terrific programming, even though we can't do it in person. We have found it's wonderful. We're getting actually more and more people viewing than we can fit in our beautiful building through this virtual approach, and people from all over the country and all over the world. So we've been able to keep up the level of programming. Let's see what people say in terms of their results. It looks like there was a lot of agreement and enjoyment of this format. So we will try to do more of it. Really appreciate everybody's participation. And in particular, I want to give a big thanks to Dr. John Schwartzberg for joining us virtually for today's program of the Commonwealth Club. And again, a thanks to the Chan Zuckerberg Initiative and to our other donors. If you enjoyed this program, I encourage you to make a donation yourself. So thanks again, John. I'm Mark Zitter of the Zetema Project, and now this virtual meeting of the Commonwealth Club is adjourned.
Hi, I'm Dan Ashley, the evening news anchor for ABC 7 News in San Francisco, and I hope you and your loved ones are staying safe, healthy, and comfortable during these very challenging times. I am also a proud board member of the Commonwealth Club, one of our most important Bay Area institutions. The club has been hosting wonderful events with exciting speakers and topics in the Bay Area for over a century. In times of crisis, good information and strong connections in our community are especially important. And during the current COVID-19 crisis, the club has really stepped up. Since March 6th, the club has brought you over 200 live-streamed events with speakers and panelists, including past governors, secretaries of state, university presidents, and noted health experts. Every program includes a live chat, so you and viewers all over the Bay Area and beyond have been able to ask these experts the questions that are on your minds. Every program has been neutral and unbiased in true Commonwealth Club style to get to the bottom of the issues that are so drastically affecting our lives. The club has done all this public service despite being profoundly affected by the crisis. The inability to hold events for the past 2 months has forced the club to cut its budget and staffing by 50%. The remaining staff are working from home to bring the community these valuable and informative live-streamed programs. The club needs your support to continue its shelter-at-home programming. Please Please make a tax-deductible donation to the club now by texting the word donate to 329-4231. That is, donate to 329-4231, or visit the Commonwealth Club website, commonwealthclub.org. We need the club to be here in the months and years ahead to help inform and educate as we figure out how to get our society and our economy safely moving again, consider changes to the way we live, and work as a result of this crisis, and take steps to prevent a future pandemic. Once again, please support the Commonwealth Club now by texting the word donate to 329-4231. That is, donate to 329-4231, or visit the website commonwealthclub.org. I want to personally thank you for supporting one of our community's truly great organizations. I'll see you on ABC 7 News and at the Commonwealth Club. Stay safe.